So now that we've had an opportunity to touch upon some aspects of literature reviewing and study goals and design, let's go a little bit into greater detail about some of the nuances of each kind of major design. So, what is the difference between a case report and a case series? They can be a little bit confusing at times because of their similarity, but a case report describes one patient. So let's say I'm a dermatologist and a patient comes to me and they have this very unusual presentation of psoriasis, just not really ever seen anything like this before. And I write up a report, basically. I write up a summary of their past medical history and their case and the signs and the symptoms and the treatment and all these sorts of things, what diagnostic things we had to do. And I published that. That's a case report. Um, it's different than if I looked at, 10,000 people or something like that. It's just one person. A case series would describe a group of people who have the same disease, disorder, undergone the same procedure. So let's say I end up getting 5 or 6 or 7 people with this same weird presentation of psoriasis. I might catalog that all together, summarize it up, and publish it as a case series. So the objective here is description. Hey, look at this. This is what happened. So the question is, well, what are the characteristics involved? Because maybe a dermatologist somewhere else in the world or reads this and they're like, oh, I just saw somebody who was kind of like this. And because of the study, this case report I just read or case series, maybe I'll try this approach and see if it works. So the idea here is to recognize that this is not something that is generalizable, meaning that just because something occurs in one person or a group of people, that doesn't mean it's going to be true of everybody. And that's one of the biggest mistakes you will often see, or misinterpretations you will often see, is someone will say, I put this patient on such and such, diet and their cholesterol dropped. So therefore this will work for everybody. No, you described one case in one person. These are descriptive statistics, right? These are not inferential statistics that we can use here. It's valuable, but we want to know where its boundaries lie. Cross-sectional studies, also known as a prevalence study, right? This is going to measure the proportion of people within a population who have and this is a key thing, a particular exposure or disease at a particular point in time. Cross-sectional studies are snapshots. Time is just this little flicker of a moment. The objective here, what is the exposure or disease status of a population right now? What is the prevalence of that disease or exposure right now? The goal here is that study participants have to be representative of the source population they're drawn from. So, let's say time is very limited or we don't have a lot of money to do something very large or broad, but we can do a snapshot. So let's say we go into a classroom and we have everybody there take a survey about their feelings about how well Stockton is, I don't know, feeding them, right? We're doing a survey about hunger and homelessness or food security. So how are they being fed at Stockton? How are they being housed at Stockton, et cetera? That is it's just a snapshot. At this moment in time, this is what students are saying, feeling, et cetera. It is the kind of thing where we are just going to be looking at statistical measures of prevalence, right? What is happening right now? What to watch out for is that we want to make sure people are representative of the study population. So let's say we wanted to do a cross-sectional study and we did a survey at a mall. And so we spend all day in the mall asking people to fill out a brief survey. Well, what's the tricky part there is, well, is the mall representing the population of, let's say, Galloway? Is it representing the population of New Jersey? Or did we do this on a holiday weekend where there's people there from Tennessee, there's people there from Georgia, there's people there from Iowa, there's people there from overseas? So it's not really going to be representative of the study population if the sample that we're working with is kind of made up of all these other different types of people. So something that we want to watch out for in cross-sectional studies. With case control studies, this is going to be comparing the exposure histories of people with the disease, with the case of interest, and people without the disease or the case of interest. So the case here are those study participants with the thing we're interested in, the infectious disease, the non-communicable disease, the psychiatric condition, the injury, whatever, compared to people who don't. So how do we know whether we're working with a case control? We're comparing people with and without the disease with their exposure, right? So let's say we want to understand the exposure histories of people who have arthritis, and the exposure we're interested in is some kind of environmental pollutant compared to people without arthritis. So people with arthritis, how many of them came across an environmental pollutant XYZ? And then we're also looking at people without arthritis and seeing, well, how many of them came across environmental exposure XYZ? So a case control is going to be best study design, best approach for identifying risk factors for a disease, right? For people who does not have the disease being examined, for those participants. So the idea here is we want to know risk factors for disease. We already know whether people have the disease or not. We know whether they have arthritis or not. So in a case control study, we're exploring the impact of exposures. So the objective here, right? This is how we want to think about all of these different things. What's the objective? How are we deciding the kind of best study design? So in this case, our objective is to compare exposure histories in people with or without the disease. What do we watch out for? Recall bias. Because what if I'm asking you, have you ever come across environmental exposure XYZ? Well, that's a little bit tricky if I'm asking people to remember. Maybe I have no idea whether I've come across this environmental chemical, or maybe I think I definitely have when I really haven't, but I've just been hearing so much about it in the news that I think, well, I must have. So this is good to use when the disease is relatively uncommon, because we want to narrow things down a little bit. We're going to use odds ratio here. So if you were to know what kind of statistical measurement you would eventually use in your analysis, you'd be calculating odds ratios. Cohort studies. A cohort is a group of people who are staying together and being followed together through time. So cohort studies are observational. We're following them through time. So the idea is if we were to do a cohort study on a bunch of kindergartners right now, and we want to see what factors lead or influence their health between now and high school graduation, cohort study, we're following them through time. What we're looking for typically is the rate of incidence of new cases of a disease or an outcome. So the chapters here, right, are going to be specifically looking at prospective, retrospective, and longitudinal. Make sure to, again, as you're going through, read those sections well, because you want to know the difference between. All cohort studies, regardless, have at least 2 time-based measurements: the initial at baseline, and then the follow-up, right? How are they at the beginning? How are they at the end? And maybe we do follow-up checkings in between the two as well. But the idea here is that we're just following people through time, and we are seeing who gets the disease or the outcome of interest and who does not. Since we're looking at incidence, new cases of a disease, cohort studies must be able to demonstrate that the outcome of interest was not present in any members of baseline. That's where that baseline assessment is so important, because let's say what we're looking for is asthma, and I'm looking at these kids in kindergarten and I want to see who has asthma and who doesn't. We better really make sure when we're determining who does or does not have asthma right now that we're doing that correctly. Because if I accidentally put one or more people into the category of they do not have asthma when they secretly did, because I didn't test appropriately, I didn't look at their medical charts appropriately, the outcomes of our cohort study is going to be impacted, and the data won't be as reliable. So we're trying to compare rates of new diseases over time in people with or without a well-defined exposure, right? So we're looking to see how does that exposure lead to disease over time? Because the idea is that everybody at the start should not have the disease or the outcome of interest. What do we want to watch out for? Loss. Imagine following the same group of kindergartners for the next 12, 13 years. What if some of them move? What if some of them decide they don't want to participate anymore? If we're doing a retrospective study, well, what if we can't get a hold of their pediatric records or their medical records over time? And so that can be a big thing to look out for when it comes to cohort studies. The big thing with longitudinal cohort studies, again, is going to be loss of follow-up. Since we are looking at new cases of disease, we will be able to calculate incidence ratio or relative risk. So that's going to be the main statistical measure we'll be focusing on. Now, experimental studies tend to be the kind of studies a lot of people think about when they think of research, because what's nice about an experimental study is we can determine causality. The difference between an experimental study and an observational study, right, is with observational studies, we are looking at correlations. I can't exactly assign causality because there's so many other factors. But in a well-designed experimental study, we can get closer to saying A causes B. So a controlled trial is an experiment in which participants are assigned to either an intervention group or what we sometimes call a control group. So this group of 50 people are getting the vitamin. The other group are not getting the vitamin because we're curious to see if the vitamin impacts, let's say, sleep quality over time. Now, in a randomized control trial, people will be randomly assigned to the group. The remaining people are assigned to the control group, and all participants are followed forward in time to see who gets the outcome and who does not. So the difference between the controlled trial and a randomized controlled trial is with a controlled trial is some people get the intervention and then they're sort of just compared to another group, right? This sort of, and then just the general population, which is nice, but we really want to get that randomized controlled trial. Why? Because of placebo effect. Because we want to know, does the outcome, whatever does or does not occur, does it happen because people have the expectation that the vitamin will help them sleep better? Or is it because there's really something in this vitamin that's helping them sleep? So if we're doing an experimental study, the intervention, the types of controls, how people are assigned to different groups, the endpoints, right, all have to be very carefully designed and very carefully constructed, because we want to, what we're basically going to, out at the end of the study, say is this does or this does not lead to this outcome, which is a pretty strong statement to make. So we're looking for causality. What we're going to basically be really looking for here is compliance, because we want to make sure people, if we are telling you have to take this vitamin 3 times a day, I need people to take the damn vitamin 3 times a day. If they don't take the vitamin 3 times a day, our results aren't going to be what we need them to be, and I won't know whether or not the treatment was effective. So we got to make sure people are compliant with all aspects of the study. And what we're looking for here regarding statistical measurements is efficacy. Qualitative research is very different than the kinds of research we've been looking at so far, which is more quantitative research. So quantitative research is structured, right? Hypothesis driven, as we've been looking at so far. And we have data that can undergo some kind of statistical analysis, odds ratio, relative risk, et cetera. Qualitative research, though, is subjective. These are people's experiences, their words and stories. So we use interviews, focus groups, we observe the world around us and take notes, and we identify patterns and themes and concepts that build new theories. So qualitative research asks questions like, why do people feel this way? How is this feeling this way? That quantitative research can't always address. I can have people fill out a quantitative survey about anxiety or depression, but let's face it, that's different than if I sit down in front of somebody and say, explain to me what your anxiety and depression feels like. So quantitative is not better than qualitative. Qualitative is not better than quantitative. Again, not to be too repetitive here, it comes down to our study goals. And our study goals are defined by our literature review. So it comes down to, well, what is it I want to know? Qualitative data analysis is very different than quantitative. It's a whole fascinating experience in of itself to do, but there's no statistics involved with it. Instead, it is learning how to really identify and recognize themes and sub-themes and findings from words, from text, from narration. So With qualitative data, we're collecting textual data. And yes, that can include words, but also images or visual representations in that way. And we're looking for themes here. We can use what's called phenomenology. We can use what's called grounded theory, ethnographies, or case studies. So notice how a case study can be both qualitative or quantitative. It depends on the kind of data we're collecting. Typically, we're going to use interviews. With ethnography, we do not interview people, we observe people, we observe the world around us. So maybe we want to do an ethnographic study on how people act at football games. And so I just sit there with my little notepad and I take my notes and I'm just sort of writing down how people act, their body language, how they vocalize, the words they use, the swear words they use, the clothing they dress up as, the what makes them scream, what makes them sad, what makes them happy, right? So I'm just observing the world around us. So phenomenology, grounded theory, ethnography, case studies. Again, when would I pick one versus the other? It comes down to what the goal of my study is. Correlational research is typically going to use population level data to look for associations. The variables that we're going to be looking at here in correlational kinds of research are usually grouped, or what we call aggregate statistics. So what's the proportion of a population that has a particular characteristic, or the average value of that variable in a population? So in the correlational or aggregate studies, we're just looking at correlational data. We're looking at data grouped at the population level. There's no individual level data. So what does this mean? Well, let's say our study question is, does this population have a higher rate of exposure or, with a higher rate of exposure, have a higher rate of a disease? So now instead of looking at individual reports, we're looking at data from the CDC. We're looking at data from the World Health Organization. We're looking at data from the state's Department of Vital Records and Statistics, right? Existing data. There's no individual participant. So with correlational or aggregate studies, we're not interviewing people, we're not doing surveys, we're looking at data that has already been collected, that exists at the aggregate population level, and we're looking for associations between exposure and outcome. The main requirement here is that this topic hasn't already been previously explored using individual level data, because if we already have that data at the individual level, why are we doing it again at the population level? What's it going to tell us? So one of the key things to look out for is this phenomenon known as ecological fallacy. And here's the way I always try to explain ecological fallacy. Ecological fallacy is making the mistake, or maybe not the mistake, but maybe, let's say, making the jump to a conclusion of saying that just because something is true at the population level, that must be true at the individual level. So, for example, we know that higher consumption of alcohol is associated with breast cancer. And we know that at the aggregate level. We know that with data collected from hundreds of thousands of people, right? Huge aggregate level data, population level data. That population, as we see alcohol intake go up, we see breast cancer rates go up. Now, this is good for public health. This is good for creating evidence. So we want the American Cancer Society, we want physicians and dietitians and nurses to know this so they can counsel people and say, we would ask you to consume little to no alcohol to reduce your risk of breast cancer. Now, the ecological fallacy would be for me to say to somebody, if you never drink alcohol, you will never get breast cancer. Or if you do drink alcohol, you absolutely will get breast cancer. I can't say that because we're using population-wide, population-level data. I can't actually take any of that data and talk to an individual person and say, this definitely will or will not happen to you. We can't do that. And yet we see this kind of mistake or this kind of leap in logic made all the time. Instead, what we can say to people is, populations, groups of people who consume more alcohol seem to have a higher correlation, a higher risk of breast cancer. Those who drink the least amount of alcohol seem to have lower risk. So we can use these to create guidelines, not promises, but we can use them to create guidelines. Lastly, synthesis research. The goal of synthesis research is to take as much existing knowledge from previously published research articles and studies and synthesize them. This is excellent research to do in healthcare because ultimately, in healthcare, what do I care what one or two or three studies say? I want to know what 50 studies have said about the role of fiber intake and digestive cancer, or the role of meditation and autoimmune diseases, or whatever it is I'm interested in. I want to know what dozens of research studies have shown because I am a healthcare professional and I'm doing my best to provide evidence-based care to my patients. And I want to know, what does the mountain of evidence out there say? So synthesis research allows us to say, this is what all of the available, currently published, peer-reviewed data about this topic currently has to say. So our data source is published literature. It's basically a gigantic literature review. Now, our synthesis reviews, our synthesis research can be what's called a narrative review. It can be a systematic review or a meta-analysis. And again, when would you pick one versus the other? Hopefully you can say with confidence, what is your study goal, right? What is your primary question? What are the conclusions about this topic that are supported by previous studies? That's narrative. When all previously published studies are examined, what's the larger conclusion that can be drawn? That's going to be more systematic. When the results of all previously published are merged, what is the summary statistic? That's a meta-analysis. So again, depends on what our goal is, depends on what our question is. The limitation of things to watch out for here is sometimes studies can't be fairly compared. There might be limited number of studies out there. We can only do so much. With narrative and systematic reviews, there's no statistics. Meta-analyses will have some summary statistics, but for the most part, it's going to be more narrative in nature in terms of what the findings are. So with synthesis research, this helps us to become experts in a field because now I've looked at dozens and dozens, if not hundreds of studies on a particular subject. I really know what's going on. And for healthcare professionals, especially clinicians, but other healthcare professionals too, narrative reviews and systematic reviews and meta-analyses are some of the best studies and research that we can get our hands on, because I want to know ultimately, not one study says this, one study says that. I want to know what the conclusion, as best as any of us can draw, what does the research seem to say? So as you're going through these, as you're going through the chapters, make notes to yourself. When would you use one versus the other? What are its major benefits? What are its major drawbacks? You really want to be able to identify, oh, this would be a case study, or this would be a cohort study, or this would be an example of when you do a meta-analysis, et cetera. Start to make sure that you're really getting comfortable in these areas.